Thank you very much for joining us for the how to avoid it. It's not so much the positive topic of how to do free gingival grafts, but the more relevant how to avoid failure. Now, the reason I thought of this particular topic is because I teach soft tissue grafting, and quite commonly when people start their first graft, they have problems. So now, just to make sure the audio is okay, can you please type your country where you live in the comments so we can see that you're actually hearing the sound coming through. Now, I'm going to go through the step-by-step on how to do a free gingival graft, which I think is, I guess, the basic building block that we start with grafting. And then I will talk about some of the things that I've had a failure with, and also I very kindly had a friend share one of his cases that just failed recently, and I'll go through some of the issues that case shows. If you do enough soft tissue grafting, you are going to get a failure. Now, I will mention one other thing. This has got nothing to do with grafts, but the entire production team that are sitting over there that you can't see are all sick. So if you hear the random cough, that's where it's coming from. It's not a ghost. This is sort of a typical case that I would have started my career doing soft tissue grafting. So we're just seeing to see a 1 millimetre of recession on this case, and this is a patient who is only about 16. So at 16, she already has 1 millimetre of recession, and she's going to have orthodontics, which will be mildly expansionary. Now, there's a lot of debate as to whether you do soft tissue grafting before or after orthodontics. So do you do it to prevent recession, or do you do it to fix recession? I do both, and it depends on the patient. So we have a discussion with the patient, and then from there we decide which risk they would rather avoid the most. In this particular case, the patient and I felt that it would be easier to do the surgery before there was a recession. So the issue you can see here, and this is a very common one, is that there is no attached tissue. So when we inject local anaesthetic here, the tissue lifts up all the way to the gingival margin. So she had a frenum as well that was pulling, but there's a tiny amount of keratinized tissue. There's no attached tissue at all. So we need something there to give us a stable bed of soft tissue. This brings us to really the first step. Now, the whole procedure's really got just 4 steps. And I will talk about how doing those 4 steps as a compartment, just one step at a time, is very important to the success of a graft. In fact, any complex procedure, particularly when you're doing it for the first time, where you may be a little bit stressed, compartmentalising the procedure so that there's just one little piece that you do at a time is very, very important for avoiding failure. The surgical bed for a free gingival graft is probably the most important part of the procedure, followed by the suturing. So the surgical bed and the suturing are the 2 bits where most people will have their failure. What we're trying to do here is we're raising a flap, but we're not raising a full thickness flap. When we raise a normal flap, we will lift the entire thickness of the soft tissue and the periosteum off the bone. So that's the standard flap that we're trained to do as general dentists, is to raise the entire thickness off the bone. What we're doing with a free gingival graft is that we're doing a sharp dissection. So we're trying to remove the tissue from the bone, but we're using a scalpel. And what that does is it leaves the periosteum. Now, often when we talk about a split thickness flap, people get confused and they think we're trying to be in the middle, to split it in half, but that is not true. So a split thickness flap can be just under the mucosa, it can be against the bone, or it can be anywhere in between, depending on what you're trying to achieve. With a free gingival graft, it's important that the periosteum is still on the bone, because that's where the blood supply is going to come from. So it's going to come from underneath the graft through the tissue. And it's important that the tissue is stable. So if you don't do your incision close enough to the bone, you'll actually possibly end up with mobile tissue. And I'll show you a case where I've done that myself. I've done the incision too close to the mucosa, not close enough to the bone, and the graft it looked beautiful, but it didn't provide any attachment. It still moved, just like the tissue did prior. So one of my favourite instruments, there's a whole range of instruments, and people will often ask, which scalpel are you using? I don't really mind what you use, as long as you get the job done. So one of my favourite instruments to use, particularly in the front of the mouth, is the 12D, which is the double-sided 12 scalpel. Now, a friend of mine, Dale Rosenbach in New York, told me that in the United States, this is often called a 12B. In some countries, the B and the D. So basically, it's a number 12 scalpel, and it's got the cutting surface on both the front and the back. Now, when I'm doing this type of incision, particularly in the front area here, it's best if you plump the tissue up with anaesthetic. So you want to put a lot of anaesthetic and puff the tissue up with the anaesthetic, and then put a lot of tension. So put your finger in the cheek or the lip and pull the tissue tight, and then it's just a matter of dissecting it, basically dissecting to the bone. Now, usually, as you can see, we would leave a small amount of the existing tissue there. Anything that's stable you leave, so do the incision below the stable tissue. Now, in this particular case, you can see I've done the incision down there. Some people, and I sometimes do it too, actually remove the piece of tissue. So rather than doing this kind of envelope type incision, you can actually remove the entire amount. In some situations, that will give you less scarring around the edge of the graft, and in others, it won't make any difference. To try and, I've drawn a little diagram which I hope illustrates how we do this incision. So you can see on this diagram here, the blue is the periosteum and the pink is the tissue. We're not trying to lift the periosteum. So when you use a periosteal elevator, it's blunt dissection. And if you raise a flap with blunt dissection, you will always lift the tissue and the periosteum. In this case, because we're using the scalpel, we're doing sharp dissection, and you can try and lift periosteum with sharp dissection, but you'll be there all day. It'll be like Frenching a rack of lamb, okay? It'll take you forever. So don't try. Yes, I've been watching too much MasterChef. Now, you can see here, once we do this, in some cases, if you want to, you can actually cut this entire piece off. Most of the time I leave it, but it will bunch up around the edge of the graft and leave a little scar line there. So step one, getting that surgical bed ready, okay? So now when you're doing this particular part of the procedure, you should not be thinking about anything else. So don't sit there and think about the harvesting the graft. If you start thinking about the entire procedure at once, your head becomes muddled up. So the first thing you think of is just the local anaesthetic, that's it, okay? And then you think about just preparing the bed. When you think that you've got that perfect, then you move on and you forget it. So don't move on before it's done perfectly, because then you'll have to keep coming backwards and forwards, and that actually causes what we call switching costs. So there's a myth that people can multitask, and they actually cannot. So when you change from one task to another very quickly, that's not multitasking. It's actually just doing one task followed by another. Now, some people can switch from one task to another very quickly, and those people have what we call a low switching cost. The amount of time it takes their brain to switch from one task to another is very small. Okay, and a typical example would be a fighter pilot. So fighter pilots are not chosen because they can multitask. They're chosen because they have a low switching cost. They can switch from one thing to the other. In dentistry, most of the time, if you try and concentrate on one single part of the procedure before you move on, you will reduce the chance of you having switching costs, and that will make a huge difference to the outcome. Now, when I teach people live procedures, I see them having a lot of problems with this because they tend to half do something and then they jump on and then they go back and then they go forward and go back. And all the time, their brain is focused on two things, and so it's not focused on anything. With grafts, this is particularly important. So our next step is we have to harvest. So we've prepared that surgical bed, it is done perfectly, and now we forget about it. We no longer think about that bit, it's done. Harvesting grafts is not as easy as it looks, because the rule of any bone or soft tissue graft in dentistry is that when you are harvesting it, you will think you're taking a massive graft. It's our natural tendency to think the graft we're taking is huge, and then when we actually take it out of the mouth and go to put it where it's going, we think it's tiny. Okay, and I've drawn a little diagram. Now, there's two reasons. One is just psychologically, we actually think that the tissue is bigger than it is, and there's also an optical illusion if we're harvesting from the roof of the mouth, which I'll show you in a moment. The second is that when you dissect a free gingival graft out, it loses all the tension of the surrounding tissue. It actually shrinks a bit. It shrinks about 15 to 20%. So it actually has to be slightly bigger than you plan to be the right size when you put it in position. Here is the reason why you will generally take your graft too small. So most of the time, where you can see there, most of the time we're grafting the buccal of the teeth and we're harvesting from the palate. And I've drawn two lines there, and you can see the difference in the diameter or the the length of the buccal surface of the teeth compared to the palate. And I've overlapped them in this picture, and you can see that the total length of the palate that you can take a graft from, and that's if you take a massive one, is less than half the distance around the outside of the teeth. Okay, so that when you look at it, you'll think, oh yes, I'm doing a 4-tooth graft. I'll just take the graft from beside the lateral all the way to the molar, and then it won't be big enough because the circumference on the inside is much smaller than the outside. This is why when we get to the really big grafts, we don't use natural tissues, but we might use something like alloderm, where we can just buy a piece from the shop. Okay, we can get a little big piece, 2 centimetres by 4 centimetres, and then you can cut it in half and you have 8 centimetres, and you can do an entire upper jaw with 8 centimetres. So that's why there's a limit to how much. Even if you take, I've done grafts where I've taken an entire strip from the front to the back of the palate, all the way around the tuberosity on both sides, and even then you only get enough tissue for about 8 or 9 teeth. Now, the crucial part is placing the graft. So the first one where we'll make a mistake is preparing the surgical bed. Harvesting the graft. Actually, I will talk about one mistake you can make harvesting the graft. Now, the first time you harvest a graft, you'll be quite anxious, and you'll be anxious about the bleeding, and your assistant will have been trained every time there's bleeding to put the suction there. Okay. Now, when you're doing your first soft tissue graft, be aware of this, because the very first graft I ever did, which thankfully was like tiny, I was so scared that it wasn't big enough to do a single tooth. But of course, when I dissected off, the assistant immediately suctioned the graft up. I was then one time running a soft tissue grafting course, and even the dentist assisting me tried to suction the soft tissue graft up. So number one reason not to get a failure is don't let your dental assistant suction the graft up, okay? If there's a dentist watching this who knows who she is. Now, as soon as I get the graft off, I want to suture through it so that it can't be dropped on the floor, it can't be suctioned up or otherwise damaged. So put a suture through it straight away. Generally what I'm doing is, as I'm dissecting it off, I do the sides, the top and the other side. And when I do the very last side, then I tell the assistant to go away, okay? Shoo. And if you're really worried, you could put a suture through it before you remove that last little piece. Now, the next area where we often get issues is stability. This is probably the second biggest area, if not the biggest area of failure with a graft. So one's just getting it all right with the actual preparing the bed and harvesting. Second one is suturing. Now, the blood supply must come through the periosteum. So for it to work, the graft must be tight against the periosteum, and it must not move. So if it's not tight against the periosteum or it moves, then it will not develop a blood supply. I guess another little thing to remember there is that if your graft is too thick, so if you harvest a graft that's 3 or 4 millimeters thick, it will be too thick for the blood supply to keep it alive, and it'll actually just die. Or at least the very top layer will die. Here's one of my, so this is that same graft I was continuing. Now, bear in mind, this was done maybe 3 or 4 years ago, so my technique has improved a little bit from here. There are some errors here, which I'll point out, but when you're doing grafts around teeth where possible, I see a lot of people do sutures all around the edge. Now, the problem with sutures around the edge is that they don't compress the center of the graft against the surgical bed. So the edge of it, yes, has a good blood supply, but right in the very middle, it's not pressed against the periosteum. And if it doesn't press against the periosteum, you can lose your blood supply, and then it will basically die in the center. If it dies in the center, you will lose the whole thing. So if you have teeth nearby, these sort of sling sutures are very useful. So the sutures go down into underneath the flap where you've done your dissection, and then they go up around the tooth and they tie. So they form that figure of 8 sling. It's slung against the tooth, and it's going, notice it's not the flap, it goes underneath the flap into the actual tissue below the incision. You can also just do interrupted sutures around the edge, but if you're going to do them, you need to do a few sutures through the middle of the graft to the underlying periosteum. If you don't do those sutures, if you don't have something to hold the middle of the graft down against the periosteum, then you'll lose the blood supply in the middle and the whole thing will die. Dressing the donor site is, look, there's not really much that can go wrong here except you cause the patient pain. So it can cause pain, but it won't affect it's not going to affect the success of the actual graft itself. Most of the time, I dress the graft with Surgicel, so it's a cellulose type dressing that we use for stopping bleeding. Now, before you do this though, the bleeding must generally be stopped. If there's a lot of blood coming out of the wound, then this, if there's a lot of blood coming out of the wound, then this dressing won't. So I'll often harvest the graft and then I'll just leave the site and I'll come back to it after I finish suturing. So right at the end, it's giving it time to stop bleeding. If you're still getting a lot of bleeding, do some injections with local anaesthetic that contains adrenaline into that area and really puff it up as much as you possible. If it's bleeding so much that you think you have an artery, then you'll need to tie off the artery, which is further back there. That shouldn't happen with a free gingival graft. If you're getting that happening, it means you're taking the graft too deep. There's no advantage having a deep graft with a free gingival graft because really you only need 1 millimetre. The tendency is to want to make it thicker because you think that you're going to get a better graft, but that's actually not true. Anything more than 1 millimetre is hard to get blood supply into, and you're more likely to have a failure. Now, what you can see if I go back to where I've actually placed this graft in position is that the graft is going past the edges of the bed, so the surgical incision is slightly past it. So anything part of that graft that is outside of the surgical bed is going to die. So you can see I've got a nice square graft here, but in the actual patient, it looks a little bit round, okay? And that's because some of that graft was past the edge of the surgical bed, so it lost its blood supply immediately. Now, in that particular case, I used resorbable sutures. I would not use resorbable sutures now. I tend to use mostly polypropylene or nylon, either in 6.0 or 7.0. The reason I don't use resorbable, because whilst I didn't really ever have problems with it, I now know that resorbable sutures are too likely to dissolve randomly when you don't really want them to. And also because I teach, I find that when people are using sutures for the first time, a resorbable suture they tend to be a little bit more likely to have a failure with. You can see here one of the problems with the free gingival graft is that they're generally quite ugly. Okay, they're not a pretty graft like some of our other ones. However, in parts of the mouth like this lady will never show, even though she's young, she's never going to show that part, and they are an extremely robust graft. So they're a type of graft where I have never seen them shrink over time or get damaged or disappear. So I have with other types of grafts seen the graft slowly disappear in volume or size or get damaged with recession, but free gingival grafts I've found to be extremely robust and extremely stable. So they're kind of, I don't know, they're ugly, but they're effective, okay? Now, I'll go through a case where where I've used this type of procedure. So obviously, a lot of the times with implants, we can see things going wrong and we want to not. There is one school of thought that as soon as something goes wrong with an implant, you immediately remove it and replace it. I think that's a bit unusual because we don't do that with any other type. If we have a problem with a crown, we don't just take the crown off and replace it immediately. Often, like if there's a small chip, we might try and repair it, particularly if it's new. So a tooth, if we have a tooth and it gets a cavity, we don't just throw the tooth out. So why do that with an implant? In this particular case, you can see that these implants were done a couple of years before. The patient has had resorption, which is a big problem with implants. And you can actually see the implant showing through the tissue. There's no attached tissue at all, so when I lift the cheek up, the tissue lifts all the way to the implant. And subsequently, there's probably loss of bone down to about the 6th or 7th thread in this particular case. Now, this lady doesn't have periodontal disease anywhere else, but I am concerned that if left, she will end up with threads out. Now, I've done these implants. It's not one of those cases where I go, oh, well, someone else did the implants and I'm going to save them because I'm amazing. Resorption happens. In this particular case, I've done a soft tissue graft. I won't go through the procedures again. There's a few bits that are important. I haven't done all the sutures around the edge that you commonly see. Those sutures, whilst they keep the graft in position, they don't actually compress it. So I much prefer the figure of 8 suture around every tooth or implant that compresses the graft against. Alternatively, you can do a suture through the graft into the underlying periosteum and actually pull the centre of the graft down that way. But those sutures are much more difficult to do. So if possible, try and do the sling sutures. They're easier. I went through a small stage of putting a suture over the Surgicel, the cellulose dressing, and then doing the cyanoacrylate, so basically super glue. You can use periacryl as a one designed for surgery. I find what happens here is that the entire dressing, it eventually becomes loose and it's just held in by the sutures, and then the patient finds it very annoying. So I don't do this anymore. I now just rely on the glue alone. Now, if you just use the glue alone, the dressing will stay there for about 3 to 4 days. But it relies on the fact that you must control the bleeding first, and you must also get it dry all the way around and then put the glue all over the dressing and the adjacent gum tissue. So it can't just be on the dressing itself, it has to go about 2 or 3 mils onto the actual tissue surrounding, otherwise the dressing will fall off. Also be very careful not to glue the patient's tongue to the back of their throat or to have glue go down their throat. Okay, I know someone in the audience is going to want to try this. Please avoid it. You really want to have the suction holding the tongue back. If you don't hold the patient's tongue back, the moment you put this glue on, they'll sit there and do a swallow and stick their tongue up, and then they'll glue their tongue to who knows what. So obviously super glue and cyanoacrylate is water soluble, so after 3 days they'll be able to drink and eat again. But they could think you're a little bit not their favourite dentist in the meantime. Okay, so all of those of you in the audience with a strong urge to glue the patient's tongue, please don't. Here we are. This is 2 weeks later. So if you've got a good successful graft, it will stay pink. Sometimes when they go white and look dead, they're still going to survive. So don't panic. At this point, there's nothing you can do anyway, so there is no particular point having a giant panic if it looks. But most of the time, if you see a graft 1 week later, it will look awful. Okay, so remember that grafts look awful a week later. Don't panic. 2 weeks later, they should look pink. If they don't, it's probably partially going to fail. And then a year later, we can see the grafts looking like this. So you can see that we no longer can see the implants. Okay, and here is a picture taken 2-3 years later. And we can see that not only have we covered it, okay, but the tissue has actually started to rise up the tooth. So because we've stabilised this tissue, and we now have stable, attached, thick, keratinized tissue, the tissue is now lifting up the tooth, and it has lifted higher than it was before. So that's called creeping attachment, and you can expect usually at least 1 millimetre of creeping attachment. When you stabilise the tissue will actually creep up or grow up the tissue, up the tooth or the implant or whatever it is, about 1 millimetre. Okay. Now I'm going to talk about some that went wrong, and most of these cases are mine, but there may well be some. There's one that my friend Kashyap from India has shared with me today. So this particular case, now you'll remember what are the 4 things. We need a surgical bed, we need to take the graft, we need to secure it and make it stable to its blood supply, and then we need to dress the donor site. In this particular case, I'm going to graft here. You can see once again, this lady is about in her, I think, 61. We're doing orthodontics, and I'm very concerned she has a frenal pull, but she also has no attached tissue at all, and there's no keratinized tissue. Keratinized tissue and attached tissue are not the same. You can have keratinized tissue that is mobile, and you can have attached tissue that's not really keratinized, particularly if you've done a graft with Elegant. I took a graft. I didn't need a particularly big one. I was just grafting the one tooth, but then I made this mistake, which is I had seen too many cases on Facebook done by, there's a very, very talented surgeon in Turkey whose name currently escapes me, and he does get root coverage with free gingival graft. But if you look at his cases, the free gingival grafts he does are absolutely massive. They go way down to about here. So don't try getting root coverage with a free gingival graft. The problem is that the blood supply comes from the underlying periosteum, and if you put the graft over the root surface, there's no periosteum, so it's going to die. In this case, you can see that that's what I've tried to do. I've done the graft and it's over here, but it's also mostly sitting over the tooth. There is no blood supply under that. If you have no blood supply underneath, if there's no periosteum under the graft, it will die. So you can see the actual surgical bed's down here and the graft's up there. Going through all the usual stuff, and here is my graft there. Now, when your graft looks like that sort of 2 weeks later, that's bad, okay? It's going to die. It's not looking pink. It has no blood supply. There is a tiny bit that's going to survive just along here, but that's a very disappointing amount of graft to get for such a big piece off the patient's. And so when we look at the final result, I got like 1 millimetre of tissue. Very disappointing, mostly because I put the graft up over it. Now, if I put the graft down here where I should have, after about a year, the tissue will have crept up an extra, I would have gained an extra millimetre of creeping attachment. But because I haven't, I've put it down. So that's one of the more common mistakes, is to try and get root coverage by putting a free gingival graft over the root. If you do that, it will die. So don't do it. I have tried it. I don't try it very often because I know it's a mistake, but I have tried it twice, and obviously both times it died. The second mistake you can make is to not remove enough tissue so that the surgical bed is not stable. So if you don't do your incision down to the periosteum and there's tissue overlying the periosteum, you can end up putting the graft over mobile tissue, which is what I did. This particular case, I actually did at one of my very first soft tissue surgery course, so it's about 3 years ago. The actual surgery went very well, but if you look at the surgical bed, you can see there's all this meaty tissue here, okay? That's the muscle from the mentalis. So I haven't done the incision down deep enough to get to just above the bone. And this is quite funny because my IT guy is looking a bit pale over in the background there. I think he might faint. He hasn't seen a lot of these soft tissue grafts. So the incision is not deep enough, and so you can see there's muscle here, and when we put the graft in, it all looks beautiful. I've done the slings. I went through a Teflon suture stage, okay? Teflon sutures are my favourite, but the problem with them is that in Australia you can't buy them in the really fine, you can't buy them in the fine gauges. So this is like 4.0. I don't like to use 4.0s. It probably doesn't make any difference. I just don't like the handling because it's too thick. So it all looks very nice, okay? Looked very nice when it healed. But when I saw the lady a year later, I could pull her lip and we had keratinized tissue, but it wasn't attached. The entire graft would just move the way the tissue had done previously. So I put the lady through a surgical procedure, basically gave her keratinized tissue, but not attached keratinized tissue. So in this particular case, it was a failure because of that. So two main things: make sure that there's a blood supply underneath and that the graft is compressed, and make sure that don't let your assistant suck the graft up, and make sure that the surgical bed is prepared down to periosteum so that there's no mobile tissue. Now, once you have that sort of skill, you can then go on and start using that sort of technique to then do some of your subepithelial connective tissue grafts. So some people call these a free gingival graft, but the moment you remove the epithelium off the free gingival graft and put it underneath a flap, it then becomes a subepithelial connective tissue graft. And we can do things like this. It's using much the same technique. This this particular root here, there's a 4mm probing depth, and we've got a 4mm recession. So we've got 8mm loss of attachment there. We've removed the furcation by barreling in and done a crown prep, and then put a nice graft. Now this graft is using the same principles, but we've removed the epithelium. So we're now going to call this a subepithelial connective tissue graft. Some people just like to call them a connective tissue graft because it's the surface layer of the tissue, and other people, but technically once you remove the epithelium, it becomes subepithelial. The sling suture holding it down is very similar, but then we pull the flap over the top. Once again, don't use resorbable sutures. It was a stage I went through when I started, but I wouldn't use it anymore. As usual, when you get healing, this is sort of about 6 weeks later. At 6 weeks, don't be alarmed if the tissue doesn't look very good. Usually, 1 week is going to look dreadful, but at 6 weeks, often you've got a little bit of recession of the graft, and that will be the worst that it looks from a recession point of view. It's quite common after between 6 and 12 weeks for a graft to then creep up the tooth again, which is what happened here. So you can see we went from having 4mm of recession and then a 4mm pocket to having about 1 to 2mm of recession and a 1mm probing depth. And you can see I'm probing quite hard and we're getting blanching there. In these sort of cases, you want to barrel the tooth in. So I'm barreled the tooth in like this to remove any furcal undercuts. And then we go for a crown. Just to give you an idea of how the tissue progresses over time. So you can see the amount of tissue, the amount of root structure showing above the tissue at this particular point. This is a year later, about the same. And then this is 2 years later, exactly the same. So we've had absolutely no deterioration of that, despite the fact that the original loss of attachment is down to about here. Okay. So that's the sort of things that we can do once we start to get proficient with these procedures. Now, a friend of mine from India, Kashyap, has just shared this case online today, and he's given me permission to use it. Now, the mark of a good clinician is not only the cases that they do well, but excellent documentation of the ones that don't go well. It's very hard to document a case when it doesn't go well, and every dentist who's done soft tissue grafts has lost one. So the only way you never get a graft that you lose is don't do any. You will, at some point in your career, will lose one, and quite commonly in your first 10, you will lose one because you're just not very good. It's better if you don't, of course, but that's the reality. This is the case here. It's a area where implants have been done. It's been taken off Facebook, so it's a bit low res, but it's area where implants have been done, and there's no attached tissue, there's no keratinized tissue. So if you pull on the cheek, it is mobile all the way to the middle, and if you lift the tongue, it's mobile all the way to the middle of the ridge as well. So there's no decent tissue, and we know that around implants that can cause a lot of bone loss because the tissue is not sealed, and bacteria will get down between the gingiva and the implant very easily. Now, the actual surgery here is not too bad. In this area, we tend to get nervous because we know the mental nerve is down there, so check your cone beam first and have a really good idea of the measurement. This particular incision is not bad. I think there may be a little bit there, but that shouldn't be the reason the graft failed, whether there's a little bit too much mobile tissue. That won't generally stop a graft from working, it just means the graft is not stable. I think this incision is quite fine. The suturing the flap down out of the way is fine too, so this bit is fine. I generally don't do this. I don't do it that often, or I do it after I put the graft in place, but it doesn't make any difference. It's quite neat to do it. So up until now, everything's gone quite neat. Okay. This is where things have gone wrong. Now, this is a beautifully harvested graft. The issue is it's so beautifully harvested that it's actually too thick. It's too thick and it's actually bigger than the site. So 99% of us, our first grafts are too small, including me. Like the first graft I took was so tiny that the assistant could suction it up and I could harvest another one from the same spot, and we still was smaller than the average one that I do now. So this graft is beautiful, but it's quite big. It's quite big and it's quite thick. Over here it looks like it may well be 3 millimeters thick. Now, you won't get blood perfusing out of the periosteum through 3 millimeters of tissue. So even if the base of the graft survived, the top will do. And I have done this too. So this is how you get good, by doing stuff and then not doing it again. When we look at this particular picture here, it's not looking very healthy. And the main issue is that there's probably not enough pressure in the center of the graft against the bed, and also the graft goes past the edges. So we have bits of the graft that are past the edges of the surgical bed. So those sutures in those areas are not really helping hold the tissue down. And I would have possibly gone down underneath the flap and then over, and then you would get a compression. Alternatively, you need to suture through the graft here. Now, Kaja told me that he, because the graft was so thick, he was struggling to suture it to the periosteum, which he's basically worked out the issue himself. So the issue is almost all in this picture here. The graft was not compressed against the periosteum enough. It went past the edges of the surgical bed, so we're losing blood supply, and it was too thick. So basically, we couldn't get enough blood into that graft for it to survive. Just the apical repositioning, though, quite, as I guess, slightly ironic, the apical repositioning of the flap will probably actually grow attached keratinized tissue. So there is quite a good chance when it all heals that the situation will actually be massively improved, despite the fact that the graft that was put over the top. So all we would have needed to do, this graft was perfectly done except too thick, so make it thinner, trim the edges so that the surgical bed was sitting underneath the graft, and have some type of suture that compresses it down. It would have worked beautifully. Hang on, I've just lost a couple of slides. Here we can see the graft looking dead, and because he's done that, he's getting one of the blue logos, because the blue logo we award on Right for people who consistently demonstrate excellence, which is what this particular dentist has been doing. And to show a failure is, you have to be a good dentist to show your excellence. You have to be a great dentist to show failure. So thank you very much for letting me share that case. So if I go over the main causes of failures, okay, I've done a list here. I hate lists, but here's a list because I want to keep it very simple. Number one, however, when you were in your early career doing soft tissue grafts, however long you think the graft will take you to do, book 3 times longer. So if you think it's going to take 1 hour, book 3 hours. Okay, in your early stages, you will see someone like me do one, and they will look like they're going very fast. Okay, or if you watch someone else, who's been doing it for years, it will look like it takes an hour, and you go, wow, that's so fast. And then you go to do it yourself, and you think, I'll book myself an extra half an hour, and then you'll be running late. So right when you're doing the suturing, which is the bit where you're going to get the failure, you'll run late and you'll get stressed, and then your brain goes crazy. Sedate the patient if possible. You don't have to sedate them. You can do anxiolysis, but almost anyone who's getting a soft tissue graft in my practice, I will give them either 3 milligrams or 4 milligrams of lorazepam. L-O-R-E-Z, I forget. I'll send you the link later. Okay, lorazepam is a long-acting benzodiazepine. If you can get triazolam in your particular part of the world, that's good too. Triazolam has got a shorter acting time. Lorazepam, I like it because I do a lot of long procedures, and even at the end of the procedure, they're just as dozy as they are at the start. And most of the time, if you give them 1 milligram, they'll just be a little bit chilled. 2, they're a bit chilled. 3 milligrams, they're usually like, if they're a lady, they'll be pretty toast. They'll be so chilled they'll fall asleep, and they'll usually get amnesia, so they won't remember the procedure, which is what I want. It's not a particularly gruesome procedure. It's just that in your early stages, you'll be stressed, and it's easier if the patient's chilled out. So that alone will increase your chance of success, because you won't have part of your brain distracted by the patient, particularly when you go to harvest the graft, because you know that those injections on the palate are going to hurt, and so you're possibly going to get a little bit stressed from that, and then it's going to take you ages, and then so basically chill the patient out with drugs, okay? I tell the patient, they can take the drugs, or I can take the drugs, but one of us is going to take it, okay? Dissect down to the periosteum. If you don't dissect down to the periosteum, you'll get a free gingival graft that's not attached. It will move. Make it thin, 1 millimeter. Make sure it's bound tightly, so either use the sling sutures that go around the teeth and then down over the graft into the underlying surgical bed, or do sutures that are actually like little button sutures that go right through the graft to the underlying periosteum. They're quite hard to do though. Okay, it's quite a lot harder to suture through the graft, grab periosteum, come back out again. To do that, you need very fine sutures, and if you're doing that, it's quite easy for them to catch on the bone and then bend. Lastly, non-resorbable sutures, and most importantly, the most important part of this procedure is actually not the technical bit, it's keeping your head under control. When you're starting out with grafting, it's easy to go a bit crazy and you lose control of your procedure and you lose control of yourself. And you go, oh, I think that will work. Okay, so you need to just think about one part at a time. This goes for all big procedures, but particularly grafting when you're new. One part at a time. You do anaesthetic and that's it. You do preparation of the surgical bed and that's all you think about. Okay, don't think about anything. Don't think about all the other stuff because you'll get stressed and overwhelmed by how much there is. If you want to know more and know this in more detail, obviously we'll be running a course in Sweden. It won't actually be snowy despite what the picture shows because it'll be in September. Or I'm running a course here in Australia with Flora and Bobby from Romania, and the two of us will be teaching together. Alternatively, the cases that I've showed today, most of those cases are actually available on the Academy. So we have full-length surgical videos that show the entire procedure with me doing, I think, which are on the Academy, which you can log into. Now, if there's any questions, fire away, okay? I'm here to answer questions. I'll go and grab my phone, which should have questions coming in. And here we go, a whole stack of questions. Here's one from Pinak. How do you manage the mental foramen if you're doing a free gingival graft with vestibular in the lower first and second? So the way you manage the mental foramen is don't cut it, okay? The way I do this is I would, okay, this gets into finer details of the incision. So if I go, I'm gonna go back to original picture, right at the start. Hang on, I'm going to go off camera and find my original picture. Hang on. Right at the start here. And, okay. This particular incision I have just done down to the bone. What you want to do is, first, you need a cone beam if you're going to do grafts in this area. Then measure how far down the graft is, how far down from the gingival margin or the bone level the mental foramen is. Now, if the mental foramen is not very far down, then you need to consider whether this is a good idea or not. Alternatively, if it's 15 millimeters down, which it commonly is, measure the length of your scalpel blade. Okay, and make sure you don't go 15 millimeters down there. Stop well short of that, okay? Alternatively, you might want to consider a different approach. So there are different ways to get under here. You can do blunt dissection with scissors. So you can put the scissors down and open them. Basically, just don't cut the nerve, okay? There's no way, for a free gingival graft, there's no way around. The good thing about free gingival grafts, they're only about 4 or 5 millimeters wide. They don't need to be much wider than that. So 4 or 5 millimeters is definitely wide enough. So most of the time you'll have 8 to 10 millimeters of clearance from the nerve just because the graft is quite narrow. They don't often get better by making them massive. Mostly when you're doing the really big ones, they're in edentulous areas, and so you have no problem with this. Okay. So dentist Phaeton, how do you manage vascularizing between the graft and the periosteum? It will occur naturally if the graft is no more than 1 millimeter thick and if the graft is compressed against the periosteum. So your suturing must compress the graft and the graft must not move. So stability is a very important part of soft tissue grafts. If you don't have stability, then you can expect the graft, if the graft is moving, it's not going to heal. That goes for soft tissue grafts and bone grafts and any sort of graft that cannot move. So you must have it stable and you must have the graft compressed against the periosteum and you must have it no more than 1 millimetre thick. So if you've got a big 2 millimetre thick graft, it's going to die. How many millimetres of adherent gingival tissue can you add with free gingival graft? You can make them as big as you like, I guess. Because the blood supply is coming through from the underneath, it doesn't matter how wide the graft is. Okay, obviously, if you have degloved the entire mandible, then that's too far. Okay, most of the time, you're not going to get much benefit from going wider than 4 or 5 millimetres unless it's an edentulous area. So if you have an edentulous area, then you are going to get some benefit from going wider, but most of the time, if you're just trying to stop recession getting any worse or prevent recession, 4 or 5 millimetres is enough. Generally, you're only going to get about 1 millimetre of creeping attachment. When I do free gingival grafts, I'm telling the patient this is to prevent further recession or to give us a good, healthy area to do implants or to protect implants that are going to get exposed. I don't tell them it's to cover the recession. That's just a bonus. In fact, every time I do a soft tissue graft, I tell them that coverage of recession is a bonus and that the main reason we're doing this is to avoid further recession. It's to make the tissue stable and robust. It's not to cover. The recession coverage is a bonus. Here's one from Samir. How do you de-epithelialize the tissue? What instrument? Okay, I've seen people use actual razor blades to fillet the epithelium off. This is incredibly difficult. I can't do it. I've tried. It's too technically difficult. I actually just get a scalpel and I scrape. So I hold the graft there and I just hold the blade on its side. So I'm not cutting. I'm scraping with the kind of the side of the blade. It's like scaling a fish, okay? You're just sitting there scraping the blade along the graft and you keep scraping until all the shiny tissue is gone. Now, you have to be careful not to push too hard because if you're scraping and you push too hard, then you chop your graft in two, which is fine. It's just a lot more difficult to suture because now you've got to suture 2 grafts and you can't charge the patient a second time if you do that. This is another one from Sipa. Suture passes through the gum graft. Can it affect the gingival graft or you do it for stability? Okay. When you suture these grafts, you can do the interrupted sutures around the edge, but you have to do something in the middle to hold the graft against the surgical bed. Actually, not so much if it's a tiny one, so if it's only 3 mils wide, it probably doesn't matter. But once you start getting into the big ones, you need something to compress it down. So I use a sling suture, so into the tissue below the incision. You have to kind of watch this get done. So go and watch the video. If you watch the video, it'll be very clear, okay? But you need the suture going down into the surgical bed below the graft into that tissue, engaging the tissue, and then up around the tooth, and then you tie, okay? That, because it's held down here and behind the tooth, it slings or presses the graft against the bed. Otherwise, you can do like a button suture where you go through the graft, through the periosteum, and then back through the graft. Those are very technically difficult. You have to have enough thickness of periosteum, and you need to be. It's just really difficult to get it through that. If you have a graft more than about 1 millimetre thick, you're going to have trouble getting the graft to hold down like that. Would your graft size thickness change according to the tissue biotype? No. Okay, the graft should be 1 millimetre thick, 1 to 1.5 millimetres thick. If you make the graft thicker, the graft will end up thicker anyway. Okay, so if you do a 1 millimetre thick graft, when it's healed, it's going to be thicker than 1 millimetre because the underlying tissue, I don't know what happens, it just does. Okay, it ends up slightly thicker than when you start out, but it doesn't need. If you make your graft really thick, then it's just going to die. So don't make it really thick. 1 to 1.5 millimetre, absolute maximum. Also, if you harvest a really thick graft off the roof of the mouth, it's really painful. So if you can when you put the scalpel through that tissue and you do your incisions around the edge of the graft, and then you start filleting the graft off the roof of the mouth, you can kind of feel the change in density of the tissue. The scalpel will tend to slide under that really dense layer and then it will easily follow the tissue. Now, take your time, obviously, because if you cut your graft into 5 pieces, it'll just be mincemeat, okay? So often people, when they're doing this, they're not going slowly and carefully enough. In their early days, they tend to rush. and they're in a big hurry and they get all stressed and then they stop thinking and then they just cut the graft into pieces. Don't go more thicker than 1.5 mm. Okay. How quickly can you do a failure case? I think it's how quickly can you redo. So the tissue on the roof of the mouth will grow back in 3 months and then you can harvest it again. Whether your patient still has trust in you after the first failure is another question. Depends on how well you've discussed failure with the patient beforehand. I would expect, you know, if you're doing these sort of, when I do new procedures, I always do them on patients who I'm not charging and I book a long period of time. So if you're doing your first one, first of all, you should get some proper training. And secondly, book like an entire morning, so 4 hours, so that you have nothing else to think of, no distractions, preferably on a day where there's no one else in the clinic to talk to you. Take lots of time, just plod through it bit by bit. If you do a failure, then you've got to wait 3 months and then you can do it again, okay? The more times you do surgery, though, the more difficult it becomes because the tissue where you're putting it starts to become scarred. Now, scar tissue is actually quite good at providing thick attached tissue, but it's very difficult to work with. So it's difficult to do incisions and it's difficult to do sutures. Do you prep the surface of the tooth with citric acid or tetracycline? Okay, mostly a free gingival graft is not going to be touching the surfaces of the tooth. So if you put them over the surface of the tooth, remember we talked about that, you'll get a failure. So it's going to be, you don't need to prep the surface of the tooth because it's going on the periosteum, not on the tooth. Usually when you're putting it over implants, there'll still be tissue over the implants. You're just dissecting the tissue and putting it. So if we go to that second case, I'll find it. It's coming up somewhere here. Here, this one. So when I did the incision line was just below the gingival margin. Okay, and you can see it here. See that the 1.5 millimeters of gingival margin is still there and the graft is below that. So you shouldn't be putting these grafts onto implant surfaces or root surfaces. If you are, you're probably going to get a failure. So if you need to put them against a root surface or against an implant, you want to raise a flap and go to a subepithelial connective tissue and cover the graft with a flap. If you're going to cover, you must de-epithelialize because otherwise you'll get a cyst. And I've actually got a big, I've been boasting to my patients that I've never had an infection, and then just the other day I've done a graft. I haven't de-epithelialized correctly. There's been tissue build-up under the flap and then it come up like an abscess. And it's basically a cyst formed from not removing the epithelium. So that's what happens if you don't remove the epithelium properly. You get basically cyst formation between the overlying flap and the underlying graft. This is from Christopher. What is the best instrument to prepare a tunnel graft for thickening tissues and correcting recessions? Okay, so this is not about tunnel grafts, but I can answer that question. The best instrument is one used correctly with a skilled surgeon. So no instrument will make up for the fact if you're incompetent. So if you're incompetent with your instruments, then the fact that it's the best instrument in the world will make no difference. Now, I've done a tunnel graft with a sickle probe. Okay, I saw someone do it once and I thought, oh, I'll try that just to see. And I did a very nice tunnel graft. It's very slow, but you can do a tunnel graft with a sickle probe. The Pat Allen kit is very nice for doing tunnel grafts. You can do tunnel grafts if you use a Vista approach where you do the incision up in the vestibule. You can use it using your normal curettes. So the problem with an instrument is you're not thinking about the correct thing. The correct part is, do you understand the procedure and what you're trying to achieve? If you do, then you can use all sorts of instruments and still get a good result. So I've done tunnel grafts with a 15C scalpel, the small 15s. I've done tunnel grafts using a sharpened flat plastic. I've done tunnel grafts with a custom instrument that I designed at one point. I've done tunnel grafts with the Pat Allen kit, which is very nice. It has an Orban knife, which is very good for tunneling and various other things. I've done tunnel grafts with the ophthalmic instruments, the little bendable microblades that they use for ophthalmic surgery. So the key part of a tunnel graft is knowing what you're trying to achieve and how you do it. It's not which instrument. You can use all sorts of instruments. What size sutures do you use and how long do you leave the sutures for? This is from James. I use 6-0 polypropylene or 6-0 nylon or 7-0 polypropylene. I leave the sutures for a free gingival graft. I would generally leave them for 2 weeks. What I do is I review the patient at about 3 days, and then I review them at 1 week, and then I review them at 2 weeks. Now, at the 1 week review, if I see sutures that are doing nothing, sometimes you can see a suture that's pulled through or it's just sitting there loose. Any sutures that are doing nothing, I will remove them. But the sutures that are still holding, I will leave them for 2 weeks. Now, I'm not sure whether you actually need them there for 2 weeks. What they do, though, is they remind the patient that they've got a graft there and that they should be careful. The most important part with grafts is you've got to frighten the patient into submission. Okay, now the patient will want to go home and do stupid stuff. That's the reason why patients want to do stupid stuff, is they don't realise how depressing it is when a graft fails, but you do. So it's your job. You've got to kind of frighten the patient into being very well behaved. So I tell the patient, no, if you do anything wrong, you will kill this graft, okay? And then I'll have to do it a second time, and you'll go through pain for nothing. So that's not really true, but you need to frighten the patient. So then I will go, you must not eat anything harder than a scrambled egg. So they must eat soft food. If it's harder than a scrambled egg, it's too hard. If they eat crunchy carrot, they're going to tear the graft out. They're not allowed to brush the area. They must use Savicol and not brushing. They're not allowed to touch. They're not allowed to look. They're not allowed to take selfies and put it on Instagram and hashtag it. Okay, they're not allowed to do anything with the graft at all. I don't even want them to look at it, because if they sit there looking at it, they're pulling their cheek out and they can disturb it. So the less they disturb the graft, the better. So the main thing about the sutures is the sutures that remind the patient, but even more important than the sutures is giving your patient such stern instructions. Now, when you're younger and less experienced and haven't had some graft failures, you'll tend to be too nice to the patient. Go, oh, you know, it's fine, just go home and look after it. And you want to be all warm and cuddly, but later on you go, don't go home and eat because you'll kill the graft. Don't brush because you'll kill the graft. Don't look at it because you'll kill the graft. Don't do anything. Don't talk. Don't go to parties. Don't drink alcohol. Don't smoke. Don't smoke cigars unless you really, it's like a really expensive cigar. No, even then, don't smoke it. Okay, this one's from Rita. What is the best way to protect the donor site in your opinion? My opinion, which is obviously the right one because this is my talk, is Surgicel and glue. Get periacryl, which is super glue that's expensive for dentists. Surgicel, now you have to have the bleeding stopped. Surgicel goes down, cut it to size, compress it, and then quickly paint it. And remember, don't glue the patient's throat shut, okay? It's quite dangerous. This is from Dan. Can you explain the decision for the surgical bed? Okay, well, that was at the start of the presentation. If you have keratinized attached gingiva there, then do the incision below that. So there's no point cutting off good tissue and then doing it. So sometimes you'll have, like, the keratinized attached tissue gets thinner and thinner and thinner, and then it gets really narrow, and then it gets thicker again. Okay, in those situations, do your incision just at the edge of what's already good tissue. Okay, so you're not trying to remove good tissue to replace it. You're trying to remove the tissue that's flimsy and mobile. There will be a replay of this that you can watch. So the bit at the start, if you missed the bit at the start where I said how to do the incision, go back and watch that a bit again. If that doesn't make sense, you'll have to watch one of the clinical videos on the Academy. It's from Meglin. When you place a graft against the root surface of the tooth, do you condition it? No, don't put it against the root surface or it will die. Okay, if you're talking about other types of grafts, this talk is not about other types of grafts. It's about free gingival grafts only. If you put a free gingival graft against the root surface, it will die. I showed you that. I showed you mine died, my friend's died, everyone's dies if you put it against the root surface, unless you're a genius, and most of us aren't. So if I am doing a subepithelial connective tissue graft or a alloderm, tunnel graft, those type of grafts, then I will clean the root surface by scaling with an ultrasonic scaler, and then I'll scale with a 7/8 scaler or a hand scaler, and then I'll scrub the root surface with EDTA. Okay, does it make any difference? Probably not. Okay, but clean the root surface. Oh, and I also often polish and pumice it, and then EDTA. So scale, pumice, EDTA, citric acid works as well. You can also use tetracycline, because tetracycline, I think tetracycline is quite acidic, so it basically acts like a citric acid. You could aerobrade if you want to. I don't really care what you do, just get it clean. Okay, but does any particular thing work better than anything else? Probably not. I've done a lot of grafts with nothing, just scaling, and it still worked. This is from Christopher. Are the use of full-time Essex retainers with long flanges useful for donor site? Okay, if you put an Essex retainer over where you've actually put the graft, you will kill it. So do not do that. Don't be adventurous, okay? Don't try stuff. Putting an Essex retainer over where you took the graft from can make it more comfortable for some patients. Putting a Essex over where the graft is going, the movement of the patient taking it in and out will 100% guarantee will kill your graft, so don't do that. Also remember that the graft will swell in the first few days, and if you've got an Essex retainer over it and it swells up, then you'll get necrosis and it will die. So please don't put Essex retainers over the actual graft where it's placed because it will die. It's from Dipali. Can we laser donor site with a soft tissue laser for hemostasis? Yes, if you've got a laser, use it, okay? And you should shine it and do all sorts of fancy things with lasers. But I don't have one, so I just use a piece of Surgicel and some glue. I don't use sutures anymore because they just hold the donor. As I said, it holds the dressing down, but it won't fall off, and then it rattles around and annoys the patient, and it stays there for 2 weeks being really loose and annoying. So I prefer it to just fall off. Why do you prefer deepithelialized approach than single incision for connective tissue? So this particular talk is about free gingival grafts. It's not about all the fine details of connective tissue grafts. I just threw one in there because there's an extension of the skill. I do both single incision, subepithelial connective tissue harvest, and deepithelialized free gingival grafts when I'm doing subepithelial connective tissue grafts. But when I prefer one, if I want it to look as beautiful as possible, I'm going to take the deep tissue. So I'm going to do a single incision and take the deep tissue. If I need to have the most dense and robust tissue, then I'm going to take the surface tissue. The surface tissue holds up better in the long term by far, but it's just not as pretty. The other advantage with the surface tissue is you can take much bigger grafts. So you can take a graft from the lateral incisor all the way around the tuberosity. Very difficult to do that with the deeper connective tissue layers because you've got a good chance of hitting the platal artery as you go around to the back, and then you'll have a small panic. Make sure you know how to stop the platal artery bleeding if you're going to do grafting. It's not particularly hard, but it can cause you to panic. With the deepithelialized approach, will we have more post-op pain? No. The answer is no. You think you're going to, but you don't. The pain levels between both types of grafts I find are about the same. This is borne out by the literature as well, because when you take the deeper connective tissue with a single incision and then close it up, quite commonly, if that overlying tissue is thin, it will necrose, and you basically end up with the same sort of wound as if you're taking a top layer. Sometimes it actually ends up more painful because it necroses and you have the deeper tissue that's exposed, not just that. So the surface layer, when it's done well and you take a thin strip off the surface, now, if you're doing a free gingival graft, don't deepithelialize, okay? With free gingival graft, you need the epithelium there to protect the graft from the outside environment, okay? So it's only the only time we deepithelialize it is if we're going to use that as a subepithelial connective tissue graft. And if you're doing that and you cover the wound with a nice dressing, then the pain level is about the same. Now, on the topic of pain, I give the patient 4 milligrams of dexamethasone, 1 hour pre-op, usually when I'm giving them the drugs to make them sleepy. So when I give them the lorazepam to sedate them, I also give them 4 milligrams of dexamethasone, and I give them 1,000 milligrams of Panadol, or paracetamol. Paracetamol is not very good at stopping pain afterwards, but it's very good at preventing pain if given beforehand. So if you give dexamethasone and paracetamol, and then post-operatively I give them diclofenac, which the brand name in Australia is Voltaren, and I also give them tramadol, which is a narcotic. So those two drugs I'm giving afterwards, an anti-inflammatory and a narcotic analgesic. I don't tend to give things like Panadine Fort because there's too many people that are allergic to codeine and then they vomit. And the last thing you want is someone vomiting on your new surgical site. It's very bad for the graft if they vomit. All those acids and stuff are horrendous for the graft. Okay, thank you very much. That's our talk done for the day. I'll do some more on the other topics like the subepithelial connective tissue graft and so on later on. But thank you very much for watching. You can share the link to your friends because they can still watch the replay if they haven't watched it live. And if you want to see the actual full-length surgical videos, go to the Academy. And thank you very much for watching. I've had a great time. Hopefully you have too.